Thank you for joining us for today's presentation. For those of you whom I have not yet had the pleasure of meeting, my name is Harpal Aulick, and I am the Assistant Director of Development for the Neuro and Vision Sciences at UC Davis Health. I also have the pleasure of working closely with our presenter today. Our presentation will focus on cognitive behavioral therapy for anxiety in children and the recent adjustments to Zoom. It is now my pleasure to introduce the director of the UC Davis Mind Institute and Sikopoulos Vismara Endowed Chair of Psychiatry and Behavioral Sciences at UC Davis, Dr. Len Abaduto. Dr. Abaduto is a nationally recognized expert on the behavioral profiles of individuals with intellectual disabilities, with particular focus on development and use of language by these individuals. As director, Dr. Abaduto leads the Mind Institute, which is a collaborative international research center committed to awareness, understanding, prevention, and treatment of the challenges associated with neurodevelopmental disabilities. His team includes more than 58 faculty, 46 postdoctoral fellows, and 250 staff. He is still very active in research and leads the Mind's Laboratory on Language Development, which focuses broadly on the development of language across the lifespan in individuals with neurodevelopmental disorders. Thank you, Dr. Abaduto, for taking the time.
So it's really my pleasure to introduce Dr. Meg Tudor today. So I'll tell you a little bit about Meg. She joined the Mind Institute in 2017 as a psychologist and as an assistant clinical professor of pediatrics. She has a PhD in clinical psychology from Stony Brook University, and she did a postdoc at the prestigious Yale Child Study Center. And she has California educational roots. She has a bachelor's degree from California State University at San Bernardino. Meg plays a really important role in our Massey Family Outpatient Clinic. She also has roles in research. She's part of our Autism Center of Excellence and really oversees the treatment for anxiety in one of our clinical trials in the ACE project. And she has her own work that she's launched on trying to understand the impact and the role of siblings of individuals with autism spectrum disorder. She has several publications on cognitive behavioral therapy and on siblings, as well as other topics. So I want to tell you just a little bit about some of the contributions she's made to the Mind Institute, which have been absolutely, really transformative to our clinical program. She and Dr. Winder Patel started cognitive behavioral therapy several years ago, and it really allowed us to expand our treatment options for families and really, I think, meet an important need for the region. There really have not been many options in terms of children and youth who have anxiety in addition to other developmental challenges. And so this has really been a wonderful addition and really very popular, I have to say. She and Dr. Winder Patel have also tried to meet the demand by training others in the area. So it really has been, I think, just an amazing addition to the entire region. She's also been really active in the pandemic, doing interviews on radio, on television, doing Facebook Lives, doing a wonderful interview with the National Geographic to really help families deal with their anxiety and their children's anxiety during these really uncertain times over the last 12 plus months. And that's just been an amazing contribution. As a clinician, Meg is just really unusually talented. She's committed, she's respectful of the children, and she has an intuition that I think immediately creates a bond between her and kids, which is really, really unique. And so we are just so fortunate to have her as part of the Mind Institute family. And it's just a real treat to introduce her today. And so I will stop there so I don't take up all of her time so she can talk. So Meg, I'm going to turn it over to you.
As Dr. Abaduto said, I provide cognitive behavioral therapy here at the Mind Institute, and I also supervise new therapists as they begin providing this service to children. It is something that is very much needed in our community, and as Dr. Abaduto mentioned, there are not a lot of service outlets for it. So you can imagine when COVID hit and now the way we were expected to deliver this much needed service changed overnight completely. We were not providing therapy over video prior to the COVID-19 pandemic. So I am going to talk to you today, briefly reviewing anxiety in childhood overall, then talking about what that has looked like since the pandemic hit in our clinical practice, discussing cognitive behavioral therapy or CBT for anxiety, the principles behind it, and then how are we doing it? This is the question that we get a lot, is just how are you doing therapy over Zoom? Is it working? What's it like? And share some of the strategies that I have found to be most successful and that my supervisees have found to be most successful as well. So the reason that this is important, first of all, I have to set the stage here, is that anxiety is extremely impairing to people's lives, especially young children and teenagers. Anxiety is a part of normal development, right? So the world is new when you're a child or a teenager, right? You're going through a lot of developmental transitions. The world is new and can be scary in different ways, but we can treat it also, and treatment can be very successful. So I like starting out with this picture that a child drew after anxiety treatment had taken place and could now have the confidence and the mastery to face the things that they used to be afraid of. For young children, we tend to see certain anxiety disorders more than others. First of all, specific phobias are the most common. So this is being afraid of something specific, a specific stimuli. Very common examples are animals, getting shots, thunderstorms, costume characters, things like that that may come up in regular life. Social anxiety, so being very afraid of social situations, specifically because the children or teenagers are afraid of being evaluated negatively. So they might be afraid of speaking in front of others, meeting new people, giving presentations, eating in front of others, even going places where other people might be present. I have a picture of a hoodie here just to represent that many of these children that I've treated hide under their hoods or their hair or other things that they can use to cover their face. I forgot to mention I included the puppy because if you're afraid of dogs, even that cute, adorable puppy could be very, very fear-inducing and get in the way of regular life. And then, of course, generalized anxiety. So this is thinking about the future and being very worried about it and expecting really bad things to happen, like illness to self or loved ones, natural disaster, or even failure, not doing well in school. These children tend to be very perfectionistic and have very high expectations that can be extremely stressful for them. Now, in children with autism, anxiety can look a little bit different. And I want to touch on that for a moment as well. So some of the types of uncommon anxiety we might see in children with autism are things like uncommon specific phobia. This is a lot like a specific phobia, but now the content is unusual. So things like cartoon eyes, seeing people wear their hair in a ponytail, hearing someone whistle, seeing the letter I. It can be very, very different from child to child, and the types of fears do not follow some of those similar patterns that we see in other children. Special interest fear. So this is when we see a child worry very intensely about being able to access their special interests. So getting to see the garbage truck every morning, asking repeatedly if the Legos at home are safe. So the things that the child is really, really interested in and loves becomes anxiety inducing because they are wondering about it and thinking about it all the time. Fear of change, being very worried about deviations from routines, deviations from expectations, things like eating dinner later than 6 p.m., inducing a lot of anxiety, asking repeatedly all day long, are you sure we're going to be able to eat by 6? Thinking something bad will happen if that routine is not followed. So these are ones that we typically or often see in children with autism. And again, very impairing to daily life. You can imagine a child trying to get through a day at school, for example, if they can't see the letter I, or they're asking constantly about the safety of their pet at home. Now let's talk about anxiety in 2020, 2021, this past year. And it has almost been a full year that we've been thinking about this. These are some themes that could have been present, and we probably saw them sometimes amongst children in our clinic, but now these are pervasive. Almost every child I see is presenting with some of the anxiety themes I'm about to talk about. So first of all, makes a lot of sense given that we're going through a global pandemic, are medical fears. So fears about themselves or loved ones getting sick from COVID, a lot of questioning, a lot of, unfortunately, wrong assumptions about how COVID is spread, how often it's spread, how quickly it will kill you. Of course, these are young children trying to process very adult information that they're being exposed to all the time. And also children who are extremely distressed, not about the disease itself, but about others not following the rules properly and having very specific ideas about how others should be wearing their masks or social distancing, and becoming very distressed about how they are seeing this play out in the real world. Bigger picture societal fears, worry about political divides, distress over racism, and other big social constructs. Again, a lot for very young children to take in and understand, and also personally experiencing themselves. And of course, fears about the future have been a very common theme because especially older children have a sense of what the world was like before, and they keep comparing it to what we're experiencing now. So worrying about, will I get to go to school like I used to? Will life be the same as it was before? And what am I missing out on is a major worry that the children are experiencing all the time. Now, to be fair, I am sure everyone in the audience is experiencing all of these too, to different degrees, and we can all personally relate. So one thing that I think is important to keep in mind is that increased anxiety makes sense during the time that we're living in. Everyone's baseline has gone up. It's a little bit different than treating anxiety before, because now we are also dealing with some very salient, realistic anxieties that the children are coming in with. So they're part of treatment, but also they're part of regular life experience for everyone living through this time right now. And when we're treating anxiety, we think about anxiety as serving a function for us. And fear, the emotion of fear, also serves a function for us. So if something happens or we're exposed to something, whatever it may be, that makes us feel really bad, like feeling really afraid, we try to get away from it. And so however we can, we try to escape it, avoid that experience happening again, and then we feel safe. That was totally making sense, you know, in the old days. If a bear came around the corner or something, a scary animal that we ran away from, that was very helpful to us. But when it no longer is helpful to us is when we are continually avoiding or escaping situations that actually aren't dangerous to us. So anxiety can serve an important function when we actually are in danger. When we're not, it's like an alarm going off all the time, and it's no longer serving us or keeping us safe. We're just believing that we're staying safe because we're getting away from what we're afraid of. So what we are focusing on in cognitive behavioral therapy for anxiety is we are breaking that cycle. So we are no longer just avoiding or escaping situations that make us afraid. That would be this up and down kind of roller coaster-ish graph here. Ooh, get really afraid, and then the relief, getting away from it. But it happens over and over again. And while this cycle continues, children's worlds get very, very tiny because there's so few experiences that they can take part in anymore. The example of the dog earlier, avoiding a dog crossing the street, avoiding going to a park because there might be a dog, avoiding going to the store because there might even be pictures of the dog, right? It tends to just increase if left untreated, and we have this major dramatic up and down effect of the relief when the child gets away from the feared stimuli. In therapy, when we're doing exposures, gradual exposures to the thing the child is afraid of, we now have a very different pattern where there is a peak of anxiety, they experience it, and then we are learning how we can build our confidence and be okay with those experiences. Looking at pictures of the dog, watching videos, being, you know, way down the street from a dog. We're very gradually facing the fear so that the child is feeling comfortable and confident over time, not safe just because they're running away. And we're working on this behaviorally with exposures, and we're helping the child develop new thoughts about the thing that they're afraid of. Oops, I should have warned you all in case anyone was afraid of seeing a snake on screen, but it's a very friendly, very friendly, small pet snake This was a former postdoc of mine, Marcia Chinichian, who worked with a patient who had pet snakes. And this is an example of the patient teaching her to face a fear once they had graduated therapy. So she was learning to gradually face the thing that she was afraid of, which in her case was snakes. So this is just an example of the top of her gradual exposure hierarchy when she was able to touch the snake, be happy being around the snake over time, which, believe it or not, it happens. Even in a few months' time or a couple months' time, that children can face these fears. So of course, this is something that we wanted to keep providing to children during the time of COVID, but we were now transitioning to doing this kind of treatment over Zoom unexpectedly. And some of the challenges, and these are just some, I would say there's a lot of others, but we don't have time to get into all of them. These are some of the challenges that have come up of doing CBT over Zoom during the time of COVID. So of course, it's just harder. It's harder to engage children over the screen than it is in person when we have control of the environment. Children feeling somewhat less connected to the process. You know, sometimes kids feeling like, oh, it's on video, it's not the same, you know, kind of checking out early on when it's not actually going to the office and seeing the provider in person. We don't have as much flexibility with using tangible rewards like we used to. So we could, you know, be there in person and say, okay, as soon as we finish this exposure, let's run up to the cafe and grab a croissant. You can pick any croissant you want. You know, we had a lot more flexibility with how we could reward the child, do fun activities in between exposures, keep the momentum going. On the screen, we're a lot more limited with what we have in our own house or wherever we're calling from and what the child has in theirs. It also limits the range of exposures that can be done. And this is not just because of Zoom, this is also because of COVID. So for example, if a child was very afraid of meeting new people and doing school presentations and eating lunch in the lunchroom, they're not doing any of those things anymore. So we just don't have the kind of range that we had before in terms of what we can practice, and we're having to find other ways to practice them. And of course, again, we can all 100% relate, I believe, to Zoom fatigue. So a lot of times, by the time we're doing therapy with these children, they've been on Zoom school for 7 hours already, and they're pretty burnt out of the process of watching somebody talk on a screen. So these are some of the challenges that have come up in providing the therapy. And what we're finding is working. Number one, I think is very important is, you know, we're not reinventing the wheel somehow. We are still providing CBT. We're still sticking to the principles of CBT, facing fears gradually, finding new ways to think about fears, building confidence. So that's the same, but it's some of the ways that we do it over the screen are just getting creative, finding ways to help the children feel really engaged and collaborate in the process. Some of the examples I'm going to show you today are things like more integration of visuals and art, using their special interests in the therapy, integrating other types of media into our therapy. You know, we're on a screen and we're going to use the screen in ways that we can, and other ways that we're just keeping up the behavioral momentum for the children over the screen. So here's one first example. This is an example of integrating more visuals into therapy and also integrating more special interests. And we did this before too, right? We did this, but now when we're working against the screen and the challenges of Zoom, this is even more important that we're finding ways for children to get engaged this way. This would be an example of a very simple psychoeducation about emotions for young children. So if we're learning about just labeling our emotions, identifying them in our bodies, sad, neutral, happy, and we're using Baby Yoda here and examples when Baby Yoda would feel those feelings and letting the child generate times when they might feel those feelings themselves. I understand in season 2, Baby Yoda has a name now, and I don't know what it is, and I'm sorry that I'm not up to date on that. Here's another example of, you know, integrating Pikachu in. This might be for a child with less, that uses less language and might be easier for them to point to this without using a label. So showing how scared Pikachu is from just a little bit up to more, so we can get an idea of helping the child identify the levels or the gradations of the emotions that they're experiencing. This is a classic I always like to refer back to of a child who loved SpongeBob. And we were rating how likely it was for scary things he was imagining to happen. So that, for example, someone's going to break in to my room tonight and steal me away. Things like that, those kinds of generalized worries that might come up. And we're rating how likely is it using his favorite character of Gary from SpongeBob SquarePants. Not likely, Gary says woof, which is not true. He doesn't do that on the show. Very likely, he says meow. That is true because Gary acts like a cat on the show. So it's becoming very individually tailored to the child. This is not just, tell me 1 through 8, what do you think, right? We're making it very concrete, visual, and engaging using what the child knows really well and what they're interested in talking about. This is an example of a cartoon I made about myself on PowerPoint to help the children see some of the topics that are coming up in therapy. And I love to use art in the therapy that I do in drawing, either myself doing it or the children doing it. And I know I'm a little bit biased because I like to draw, but other providers too in our clinic also like to integrate art with giving the children another way to express themselves. This particular example helps to show kind of that fear sequence. So this was me when I was little. I look exactly the same as I do now. This is when I was honestly afraid of dogs when I was very young. So I can show the children, oh, I was afraid. What do you think I would do when I got afraid? And they'll usually answer, run away. You're right, I would run away. But wait, now I love dogs. I really like dogs. How could that be that I went from being so afraid of dogs to loving them? Now I'm brave when I'm around them. What did I have to do to be able to like dogs? And we go through, the steps of talking about the kind of thoughts that I might have had when I was afraid. Oh no, that dog is going to eat me alive. Compared to what kind of thoughts would help me be more comfortable around them. Most dogs are nice, maybe this one is nice. And so we would practice that. And this is just an example, of a visual that would be helpful in getting those kinds of concepts across to the children, especially over the screen, especially when they're burnt out from everything else that they have seen throughout the day, creating these kinds of engaging materials to help them get those psychoeducation concepts in CBT. Now, also, as I mentioned, letting children draw and encouraging children to draw has been very important before COVID, and now it's even more important during COVID, finding a way that they can express themselves, so they can do an activity with the provider over the screen. So here's an example of drawing anxiety. Also, we've used other types of media as well. So let's find a song, and teenagers particularly like this, let's find a song that you have heard that makes you feel that feeling, or a song that has made you feel brave in some way, whatever it might be. A lot of references to their favorite books or story characters. This means that we are reading these books and watching these movies and things like that so that we can have that same language that we can talk to them in. Also things like video games. And this is an interesting one because, a lot of parents right now feel like, oh my gosh, they're on the screen all day for school, then they want to play video games. But from the behavior psychologist point of view, if that's something they really like, we're going to use it. And that's going to be good leverage for us. And that's going to be a good common ground for us. So doing things like integrating in how video game characters might react in certain situations, or how a video game character might face a particular fear to help them buy into the process. And also getting creative with other ways that we're talking about these things, like, can you get some of your Lego minifigures and we'll put on a little show about somebody facing their fears, or how they might act in this situation that we're playing out, some particular goal that we have. So these are all examples of different ways we're integrating in the child's interests and finding a lot more common ground with them. Again, because we need to do that more so when we're doing that on the Zoom process rather than in person. Now, other ways that we have been finding just to keep the child engaged and rewarded through the process, because again, we can't necessarily do rewards the same way that we would, or do fun activities the same way we would in person before. So we're finding more things we can do over the screen or on the screen. I have a picture of the Pusheen plushie here as an example of recently doing online shopping with a patient who we both, we're on the computer already. And then we go on and say, okay, if you could get one Pusheen thing today, that being the child's favorite thing, which one would it be? And we go and find it. And the child's super excited to do this at the end of session and very motivated to do that kind of activity at the end of session. Playing games like Heads Up, which if you're not familiar, it's a word will come up on the screen, on the phone screen, and so I hold it up and the child and I are taking turns guessing what the animal is or the celebrity is or whoever on the game. Doing things like tours of the house have been very helpful during this time. So go show me your favorite thing in your bedroom. I'll show you something from my house. I have actually had several children that are extremely motivated just to see a cool thing. And they have no idea what I'm going to show them, but every week or every 10 minutes, depending what our goals are, I will find something in my house and show it to them, whether it's a Lego set or a plant or a bag of chips, you never know. But they're excited because it's mysterious and they want to see what thing is going to come next. Pets have been very heavily involved in sessions. Our pets have met each other, have interviewed several pets, gotten to know a lot about them. And in a way, very encouraging in terms of telehealth overall, getting to be in the realistic environment that the child is in, which we never got to see before. So that's actually been a plus of this process. Scavenger hunts have been a really fun way to get the children engaged. So things like go find the silliest thing in your house, or go find a hat, or I don't have this particular hat, but I'm thinking I should get this hat for these particular exercises. Go find something really funny, something green, and it can be like a race. And we're doing that again as a reward, as something fun to keep the children going over the screen. And dance parties, definitely. I could never have a talk without mentioning the amazingness of a dance party, which could happen in person and can now happen over Zoom. Now I want to show you also a couple of other things without the slides here that have been helpful over time. As silly as some of them may be, this little guy is literally a happy face drawn on my finger, and you would not believe how handy he has come in over the course of the past year in getting the kids laughing, talking, answering questions that they may not otherwise have answered when we're getting started. Also using the chat function, which we all see here and we all know well over Zoom, has been very helpful for us, including children that are very anxious. That has been a nice first step to communication before talking out loud. And I always have my handy set of markers right next to me and my notebook so that I can draw along the way so kids can see, this is live. I'm creating this for you for the concept we're talking about, something like, I'm about to give a big talk in front of 100 people. Boop. And I can put up my little thought bubble. What do you think might go in there? Anything that's keeping it from just being, oh, what do you think would happen? Which can be more dry, just verbally based. We're pulling in the visuals, the creativity, the art in ways to help them feel more part of the process. Okay. Oh. So overall, what we are finding is, number one, we're doing it. We're finding ways to get the job done and to still be helping children. And I'm glad to say, we don't have data on this from the past year. We were just thrown into all of this. It's not a research study, but from the patients that we are seeing, we are making progress and we are still being able to achieve a lot of goals over Zoom. Even when we were daunted at first, we're finding ways to make it work and make it happen. In some ways, it's more difficult, but it can still be very effective. Creative thinking is the key. And the funny part is, this is what I say whenever I do a training in the community for therapists, whenever I'm training new therapists, I always say this, that you have to be creative, and creativity is number one in making sure that your patients are engaged and are making progress. But now I say it even more than I used to. Over Zoom, we're having to find even more ways to make the exposures work and make the children feel excited about the progress that they're making. And of course, as always, we're making it work for each individual child. So as you can see from some of the examples that came up today, the kinds of rewards and special activities that we're doing, as well as the kinds of materials that we're using, are going to be very different from child to child, what is going to work best for each of them. And overall, I mentioned one positive earlier, which is getting to see the children in their naturalistic environments, which is very helpful for a lot of them. We also are getting to expand our repertoires to doing this kind of therapy online and making treatment more accessible to a lot more children. And I hope that will be a long-term change in mental health. Now that we've learned that this is possible, how can we make these kinds of treatments more available beyond the children that we would usually see in our physical offices? And just to end on a cute note, because I think it's very cute, this was a patient that I recently finished therapy with, and we created this whole metaphor about Ghostbusters. And you can see, it's hard to see because I was taking a picture over Zoom, because that's the only place we've ever known each other is over Zoom. We've never met in person. Who you gonna call Dr. Meg for Ghostbusters? I don't share this to brag. I just think it's a really good example of how the connection can still really be there, the progress can be there, the engagement can be there when we make it fun and creative and engaging for each individual child. Okay, would be happy to answer questions now.
Thank you, Dr. Tudor, for such an insightful presentation. We do have a few questions, so I'll start off by asking them to you. Let's see. Okay, first one. Are there instances when cognitive behavioral therapy can be combined with medications? Is that effective?
Yes, definitely. So the research that we have so far, and we have more research on adults than children, but we do know that some children can respond to CBT alone. Some respond best with a combination of CBT and medication. And so there are definitely times in our clinic, myself and other providers included, where we might meet a child where the anxiety is so severe, or ADHD or other comorbid symptoms are so severe that sometimes we need to take that combined approach, and that's where we see the most progress. Okay. Kind of like turning down the volume so that the child is open to the CBT.
So kind of tying into that then, what are some of the potential limitations of CBT?
Yeah, so let's see. There's so many different directions I could go with this, but let's think about limitations in terms of kind of the big picture of the child's life. I would say CBT, especially when we're talking about CBT for anxiety, and especially when we're talking about it over Zoom during the time of COVID, some of the goals that we can have can be narrowly focused. So we might specifically be working on one particular fear, one particular area of anxiety, and there might be more in the big picture that CBT, especially in our current circumstances, cannot target all of that. So for example, we have had some children come through who had a lot of school-related fears, but they're not in school right now, so there's not a lot we can practice. CBT is very much reliant on the day-to-day experiences a child has so that they can practice those skills in them. So when that is not possible, I would say CBT is pretty limited in what it can achieve.
Okay, we've actually got quite a few questions coming in.
Okay.
So let's see. How can family physicians integrate CBT into practice, or should they be providing referrals to effective therapists?
Yeah, we get that question a lot, and I'm excited we're getting it a lot. So I think there's a few different ways to think about it. I think number one, this is kind of on the prevention side or the very mild anxiety side. I think it's important that all providers, including primary care providers and physicians, are talking about the overall concept of gradual exposure, this idea that children can face and can handle the things that they're afraid of. I think that's an important just kind of philosophy and mindset for parents to learn early on, and in many cases can prevent anxiety from escalating. Parents often have a very good intuition, parental intuition, which is to keep their children safe and to keep them comfortable as much as possible. And especially during this past year, which has been so hard, that is often a priority of theirs. But learning over time, they actually can gradually face the things they're afraid of, I think is an important part of that's an important idea to be integrated into all kinds of care. And then from there, definitely, I think referrals are very helpful for finding appropriate services for children who may have more severe forms of anxiety. And we're learning more during this time about potentially some programs that could possibly be done, web-based programs that children do without a therapist. So they're more of a self-guided type of therapy experience. I can't talk personally to those. I haven't done those myself, but they may be another direction in the future, given how many children are in need of these services and how limited the actual services are in terms of being available.
So tying into that, and you may not have all the answers on this one, but given the success of CBT during Zoom, do you think that the Mind Institute will continue being able to offer this once we're out of the pandemic? And do you think this will change the way communities access services?
Yes, and yes, and yes to all of that. I think that things are definitely going to change from this. We know things we didn't know before, and it's things we would have never asked before. And I think that we've also learned that there are some children that this works better for, believe it or not. So some children, even coming to the office, being in the car, getting to the office, being, in a room that looks like a medical exam room, that's all escalating. Whereas now we're getting to see children in their homes with their pets, getting to lead in a lot easier than sometimes it had been in the past. So I think we've learned for best patient care in that regard, and in terms of accessibility, I think this will be an ongoing version of our service.
Great. Okay. So how are CBT approaches on Zoom or in person different for youth with developmental disabilities? What techniques are most effective for these kids? What techniques used for typical kids are less helpful for these kids?
Got it. Yeah, so actually a lot of the things I talked about today fit in really well with the types of modifications that work best for children with developmental disabilities. So we are focusing on making things very concrete for the child, concrete, visual, and most of all, engaging in terms of their special interests. So if I have a child whose special interest is subways, we are creating metaphors and charts and everything related to the subway system to make them excited and engaged with it. And we tend to, with the children with developmental differences, have a lot more parental involvement as well. So the principles are the same. Gradual exposure is the same. If it's the letter I or if it's thunderstorms, it doesn't matter. We are gradually exposing the child and making them comfortable with these situations. It's more about, the changes are more about just how we deliver it, how we make it really engaging for that particular child is what comes up when we talk about developmental differences. And it's a much bigger topic than this short answer I'm giving, by the way, and something that we have provided trainings on in the past at Mind, and will be planning to continue to do that in the future as well.
Okay, thank you. How young can a child be to participate and benefit from CBT?
Yeah, so in general, in research, they tend to include children around 6 to 8 as the earliest ages, but quite honestly, we've also seen children 3, 4, and 5, and the differences might be that we might spend a lot more time with the parent than we are with the young child. So we might have a brief part of the session with them about, we're gonna be brave, and you're gonna get stickers, and you can use the stickers for candy, whatever the case might be, getting them excited about it. They're part of the process. But you know, a 4-year-old is not going to talk about their anxiety the same way a 10-year-old is. And so oftentimes the more of the focus when they are younger is with the parents and how the parents are responding to anxiety and making sure they're helping their child approach the things they're afraid of rather than get away from them.
So it's a giant effort at that point, bringing in everybody.
Yes.
Okay, is this process effective for young adults? Asked somebody who has a 21-year-old son with autism.
Yes, absolutely. So CBT was actually first designed for adults and then eventually made its way to children, and nowadays is eventually getting studied and used for individuals with autism. And unfortunately, you know, as scarce as services are for young children, they are even more scarce for young adults with autism. So would it work? But, you know, I can't guarantee, but yes, we do have good data and good research that CBT is effective for anxiety in young adults. But the challenge comes with finding a provider in the area that is able to do that.
Got it. This anonymous attendee says, I love all of your creative ideas. However, I have a teen who is extremely resistant to even get started in therapy. She doesn't necessarily trust her new therapist. What can we do to encourage her and teens in general, or make it feel safer to try therapy and stick with it?
Yeah, definitely. Yeah. Teens are the trickiest of them all, right? In so many different ways. And what it generally comes down to, it's the same principle again, but it comes around differently in teens, is that we are making it individually tailored to the child, right? And in the teens case, that often means we have to match where they're at in the process. So resistance is a very normal part of the process, and it's extremely important that therapists are rolling with the resistance, you know, validating them. Gosh, I probably would feel the same way as you. You know, I can totally understand that. And starting at a place of understanding about the resistance and then moving into the things that the teen really cares about a lot, and framing everything in terms of the teen's desires and goals for the future. So we don't want to start with a teen about, you know, what their mom's goals are for them. Like, they don't care, right? At this developmental stage, it's about what do they want for themselves? What do they want for the future? You know, if they want to go to college, how is anxiety getting in the way right now that might hinder them from going to college? So it's making it very individualized, not only to the child themselves, but also to that very unique developmental stage. That would be my overall, you know, thoughts for any therapist working with teens.
Thank you. So if a person lives outside of Sacramento, they don't have access to the Mind Institute for their children's care. Are there resources or trainings that they can share with their child's doctor?
Yeah, so we have on our YouTube channel, we have several videos that we've done in the past of different trainings and different talks that relate to this topic. That are publicly available and there to share. And in the future, we will hopefully be doing some more live trainings for providers.
And after this presentation, for people that we have the email addresses of, I'm happy to share out links to the YouTube so that you can access these resources. Okay, it looks like maybe we have time for one or two more questions. Let's see. What do you do when the parent of the autistic child is the problem, not on board, not giving the time needed with the child? So have you run into the times when parents are the obstacles?
Definitely have, and I would say this year has presented even more challenges that way because parents are burnt out, they're tired, they're stressed, and so really the direction we take when that happens is we're finding a common ground with the parent first. You know, like the classic, you have to put your air, what do you call that, on an airplane, you have to put your oxygen on first before you can put on your child. Where can we assist you in getting more support? How can we structure your routine of your day to have a little bit of time for relaxation for yourself? And then how can we create one-on-one time for you and your child, which a lot of the times, you know, being able to do something like that works towards a bigger goal the parent has. So if the parent is very, very stressed and tired because their child is asking them anxious questions 300 times a day, then we can help them get on board with this if we do this, that's going to decrease. So we kind of have to go back to the main goals and then why we're doing what we do after trying to get kind of a common ground, a foundation for the parent to be in a position to start to do the work.
Thank you. How do I get a child involved with the Mind Institute? Is there a waiting list?
Yes, so we have two different routes that families can go. One is our clinic, and that does have an extremely long wait list. It is there, but we have a long wait list. We just got a new provider, and that provider, Erin Engstrom, is hopefully going to start doing some therapy groups in the future that we think will be really helpful for getting more children's services. But also, in the meantime, while that is happening, there is also the STAR study at Mind that is specifically for children with autism. And it is a study where children can get CBT or medication through a randomized control trial. And we should probably also share a link for that study on the email as well.
Okay.
And by the way, I supervise all the therapy on that program as well.
Thank you. Okay, we're going to make this the last question, but we will get a transcript of questions afterwards so that we can follow up. If you have some time, Dr. Tudor, we can go over some
Definitely.
of the questions and email it out to everybody. So last question, what's next for you in terms of research interest in clinical services at the Mind?
Yeah, so for me personally, I am going to be starting a project this summer about siblings of children with autism, and this will be doing interviewing with siblings and learning more about their particular needs so that we can use that information to inform our services at Mind for siblings. We know that siblings are often overlooked and overshadowed in a lot of family systems, and so we want to continue to create more support for them. I am also continuing to supervise the therapy arm of the study I just talked about for STAR, and so we are continuing to learn more through that study about providing CBT to children with autism that have anxiety. And in the big picture as a clinic, you know, just like we talked about earlier, we're learning so much more about what we can provide and what we can do over Zoom, and we are going to continue learning about that and creating programs based on what we've learned over this past year that will be the most beneficial for the most families.